Hello, and thank you for taking the time to watch this brief presentation. Some of the biggest challenges facing healthcare today are quietly being solved, one by one, in communities in Ohio, Florida, and across the nation. Chronic disease at $3 trillion annually is the most costly, and perhaps the most challenging. As the prevalence of chronic disease continues to escalate, 6 in 10 adults now have one or more chronic conditions, such as heart failure, COPD, diabetes, or hypertension. Lockdown mandates have only exacerbated the already high rates of drug abuse, addiction, alcoholism, depression, and sadly, suicide. Overuse of emergency department resources for non-emergency care is pervasive across larger Ohio and Florida cities. Lacking other options, uninsured and underinsured patients will routinely utilize 911 services. Along with taking up limited beds needed for real emergencies, this practice provides less effective care, is inefficient, and is very expensive. Unfortunately, it happens every day across our country. Aging in place at home is preferable to most seniors. Yet injury from falling is the number one reason the elderly require emergency care and assisted living, and this contingent of our population is disproportionately large, with 10,000 more people retiring every day. During the pandemic, we launched 20 COVID-19 screening, testing, and monitoring programs in cities and counties across the nation. Agility and flexibility were key to quickly launching and updating targeted programs as guidelines changed. In fact, most of the 20 programs were launched in 2 to 3 days. Did you know that a number of rural communities and cities are already finding solutions to these challenges? In Upper Arlington, Ohio, a dedicated team of professionals is quietly accomplishing impressive results. In fact, people travel from other states to learn from them. Responding to community hospitals, these Buckeyes were able to provide comprehensive COVID-19 programs. In 3 days, they were able to screen symptoms based on CDC guidelines via telehealth video, provide in-home testing, and perform remote monitoring of large quarantined populations. In Tampa, Florida, a crisis team organized to help stem the revolving door of patient readmissions. A reduction in readmissions of over 80% is outstanding and nearly unheard of. Financially speaking, high readmission rates for heart failure and COPD patients are costly in several ways. They cost the community in the form of 911 transports. They burden the health system with large quantities of unreimbursed readmission care. And they represent a significant opportunity cost in the form of unnecessarily occupied beds. One more example. Palm Beach, Florida initially formed a multidisciplinary team to address opioid overdoses. Their impressive outcomes with addiction and chronic disease management led them to expand their operations. Their other programs include COVID-19 screening, monitoring, and transport, pregnancy outreach, fall intervention, and alternate care for high-frequency utilizers. Are you asking who's running these programs? Who's going into the home? Who are the providers in this new care model? Physicians and nurses don't have the time. The home health model is limited and too expensive. HME suppliers are largely unqualified to provide clinical care. Call centers lack trust and influence. Paramedics and fire personnel are uniquely positioned to do what others cannot. They are trusted, highly trained, skilled, available nationwide, and largely underutilized. These first responders are, in fact, part of the fabric of our country and dedicated to their communities. Across your state and nationwide, EMS and fire departments are independently launching a myriad of community paramedicine programs to address health needs unique to their city and county. While their efforts are commendable, each one is unnecessarily expending time, energy, resources, and money. In a sense, each one is reinventing the wheel. These programs consistently operate with superior clinical and financial efficacy. Consider readmission rates. In a population of nearly 8,000 patients across multiple geographies and socioeconomic classes, HealthCall clients consistently outperform the national benchmark, even exceeding top U.S. health systems. Another benchmark is length of stay. Shortening length of stay can contribute directly to the hospital's bottom line under capitated reimbursement models. Achieving these outcomes is a testament to the HealthCall method. Most of these programs are typically launched in 4 to 6 weeks. During the COVID-19 crisis, HealthCall operationalized clients within 2 to 3 days. Within the HealthCall platform, these programs can be tailored to the unique needs of each community while still adhering to best practices and evidence-based medicine. Along with an architecture that's designed for large, nationwide deployments, HealthCall's data structure provides for common data collection across programs. This enables statewide data collection and data-driven, continuous improvement to best practices. In light of this success, we are proposing a 90-minute meeting to introduce the platform and the people who are making this happen. Talk directly with fire chiefs, paramedics, and business owners from your state. See a demonstration of the HealthCall platform and how it works, how it connects the community, and how it empowers stakeholders and care team members. Within cities and counties, HealthCall community paramedicine and mobile integrated health programs improve the patient's experience of care, reduce per capita costs of healthcare, and improve community health overall. Now, we would like to share how these programs can be implemented statewide. Thank you.